The broadcast is now starting. All attendees are in listen-only mode.
Welcome, EMS research fans, to the April 2018 Pre-Hospital Care Research Forum Journal Club. The Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by Dr. Tony Fernandez, Dr. Bill Toon, and David Page, and we are also joined by study authors, Dr. Marie Crandall and Dr. David Ebler. The study we will be reviewing today is entitled Comparative Analysis of State Trauma Triage Criteria versus Paramedic Discretion, published in Pre-Hospital Emergency Care just this past month, 2018. Now, as usual, this review is paired with an article written by columnist Dr. Tony Fernandez in EMS World called the TRIP Report, Turning Research into Practice. And this month's TRIP report is called Making the Trauma Call. We encourage listeners to check out this article at emsworld.com. This month's column, Dr. Fernandez reviews the concept of statistical significance versus clinical significance, an important concept when reading and interpreting research and then translating that into practice. We'd also like to remind everyone about a deadline that is fast approaching for the new abstract submissions, both educational and clinical, and this is for the 2018 National Association of EMS Educators Symposium and the EMS Expo International Scientific Symposium. That deadline for new abstract submissions is April 30th, 2018, so only a couple of weeks to go. This is an exciting opportunity for EMS researchers. And if you want information, you can email pcrf@mednet.ucla.edu. Now, thank you all for joining us today. Big shout out to Santa Fe Community College again for being our faithful listeners, and we look forward to some questions out from those paramedic students out there and EMS students. So let's begin, and we want to remind listeners that you can use the chat feature on your screen to type in questions and comments, and we'll bring those into the conversation as we go. So this month's article, we're looking at the Florida Adult Trauma Triage Criteria and its use in field decision-making to transport to a trauma center. And this differs from the CDC guidelines for field triage of injured patients. Previous research questions of value in having an element called paramedic judgment, or in this article they refer to it as paramedic discretion, as one of the elements in determining trauma triage and transport. So we need a better understanding of this paramedic discretion element and its value in predicting the need for certain services like those provided by a trauma center. So Dr. Bill Toon, why don't you take us through what these authors were looking at? Are you there, Bill? Did we lose Bill? Let's see. Let me see if I see him up here. Oh, I see him muted. Unmute yourself, Bill. Can you unmute yourself? Or are you muted? A little technical thing here. So, you know, while we're trying to get Bill on, we actually have study authors. So why don't we go ahead and ask Dr. Crandall and Ebler, why don't you guys, can you give us a little bit of background, first of all? What made you interested in this concept, in this idea of taking the triage criteria that you use in Florida and comparing it to paramedic judgment? Why did this even come up?
Hi, Marie Crandall and David Ebler here. Dr. Ebler is actually on trauma call right now, so may be running in and out of my office to go respond to traumas. But this was the genesis of this was actually Dr. Ebler is the director of flight services for our region, and therefore also heads up the quality initiatives for EMS. And the previous flight director, who is Dr. Bracken, they had worked on this project before I got here a few years ago. But the interest is that many states don't have paramedic discretion. Many states simply adhere to the trauma criteria and then look at the amount of under triage, over triage, et cetera. But we were interested, because we have paramedic discretion, in looking at the concordance and the value of paramedic discretion as a complementary source of patients with respect to, are they sicker, are they less sick, are we missing something with our trauma triage criteria, or could we refine our triage criteria based on what we find with these paramedic discretion patients if there are any commonalities?
Thanks. You know what? Sorry for jumping right in. I tend to do this each month. Can you back up for a second and can you introduce yourself? And I know Dr. Ebler had to step away, but can you introduce yourself and tell us what your background is?
Sure, he's actually back. Marie Crandall. I'm a professor of surgery and the associate chair for research here at UF College of Medicine, Jacksonville. I've been in practice since 2001. I'm a trauma surgeon, acute care surgeon, and I did my training at Rush and Cook County, did a fellowship at University of Washington, got a master's in public health there, and I've really had most of my career as an academician and acute care surgeon working on things like disparities and gun violence. But moving to Florida to actually work with the entire department, I've been fortunate enough to be able to work on projects outside of my general realm of disparities, gun violence, et cetera, and been able to help faculty members work on these projects.
Hi, my name is Dave Ebler. I'm one of the assistant professors of surgery here at UF Health in Jacksonville. I'm also the medical director for our flight program here, Trauma One Flight Services. I trained up at Cornell and down in Miami at Ryder Trauma Center. My interest in pre-hospital care is pretty long-lived, back from September 11th when I was a EMT and responder to the 9/11 tragedy in New York City. So it's something that I've had a long-standing interest in.
That's wonderful. Thanks for introducing yourselves and giving us a little bit of background on this. I have one other question. I think we've got Bill back. When it comes to your interest in this, Tony raised something in his article about the Centers for Disease Control guidelines for field triage of injured patients using the physiologic anatomic mechanism of injury and then the special considerations categories. Why a different set of criteria in the state of Florida? And not really different, but why is it structured differently? Why is it, a separate, why not just use the CDC criteria?
Yeah, and that's a perfectly reasonable question. The answer is that they both started organically, and actually the state of Florida has one of the oldest and most mature trauma pre-hospital systems in the country. And really the Florida state trauma triage criteria existed prior to some of the standards that are now from the CDC, and the CDC was informed by many different states, different triage criteria. Then to have the state of Florida asks the state of Florida to adopt CDC criteria is then wrestling with individual programs, individual centers, individual ACS verified centers that already have their triage criteria in place. You sort of see where that's going.
Fascinating, yeah. Bill, are you on with us?
Yes, I am here.
Great.
Can you hear me?
Yep, we can hear you. Well, the author just gave us some background. I'm just wondering if you have any input on the when you were reading through this on the methods itself, since you tend to have, be the one to look sort of at the methods. We were just discussing establish how Florida State had their established trauma criteria and the CDC and what the history of that was.
Yes, I had a chance to hear all of that, and it was very good. For whatever reason, technical stuff always continues to challenge us at some point or another. Yes. So let me go ahead and talk about the methods here, and of course the authors, when they speak, will be able to correct any of my mistakes or anything. So just real quick, it's a retrospective analysis of all adult patients defined as 18 years of age and older, evaluated by trauma activation at their facility, and the facility was the University of Florida College of Medicine. I believe that's what it was, because it wasn't clear about that. And January 1st, 2007 to the December 31st of 14, did have IRB approval, which of course is appropriate. And it looked at the comparison of two groups, one where it was activated by the state trauma criteria versus the patients that activated due to paramedic discretion. And I have to tell you, I'm always very excited when I see something talk about the paramedic discretion or talk about the gestalt or their gut response to what they believe is going on, because I know this is evaluated at the physician level, and there's a role for this also at the paramedic. I'll have some other comments on that later. So They did the available pre-hospital variables included date of injury, age, systolic blood pressure, heart rate, ISS, which is the injury severity score. And the injury severity score, something very important for people to know, is that is done after all the information has been collected on the patients. It's not something that is done as a tool in the field or anything. And typically a trauma patient that is severe has an ISS of 15 or greater, typically to fit into the standard trauma center registry type stuff as a severe trauma patient or a moderately to severe trauma patient. GCS is in there, and then the pre-hospital data was abstracted routinely by trained registers, and which again isn't a very important thing, and it was taken right from the run sheets of the pre-hospital providers, and it was at this single institution. The nice descriptive statistics were used, and you can see all of that on some of the charts, and it's also clearly outlined inside the paper. And they looked at some important things as they looked at comparative admission rates, disposition rates, and mortality rates of the two different groups of the trauma activation versus those by paramedic discretions. They looked at the outcome, everywhere from death, admission to ICU, admission to general floor, discharge from the trauma centers. And what I thought was really good is how far out they were able to get the data to follow up on these patients. So they really were able to look out for a long period of time for follow-up and outcome type information about this, which was really good. So they put it through all of its statistical stuff. I know Tony talks a little bit about statistics and stuff. I think he's better at it than I am. But they did look at the 95% confidence interval that had a p-value of 0.05, which is derived from the two-tailed t-test of significance. So I'm going to let, do you want me to talk a little bit about the results now that the method, that was just a quick?
Yeah, and I think Dr. Fernandez, Tony was going to come in with results, but
great. No, please let him. I value his knowledge.
The epidemiologist. Dr. Fernandez, you want to talk about the results here?
Covering those methods. I think you did a good job there. I just want to again thank the authors. I think it was a great study, and we found the results are really interesting. So they were able, as Dr. Toon mentioned earlier, they had a very long study period. So over the study period, they were actually able to have about over 1,500 patients that actually required activation of a trauma alert and transport to a trauma center. And what was interesting was a little over 92% of them met the Florida trauma triage criteria for transport or for trauma activation, excuse me.
I'm sorry, and you said 15,000 of them, right? 15,000 overall and then 13,000.
That's right, 15,000.
Okay. Yeah.
There was 13,963 who met Florida's trauma triage criteria. That was a little over 92%, and a little over 7% were transported because of the paramedic discretion. Now, there was some missing data, and you'll find this with any retrospective analysis. So they couldn't actually review all of these patients. There was about 636 patients that had to be excluded from the analysis because they didn't have either an ED disposition or a hospital disposition. So that made things a little bit harder on the author here. But I think they did a good job working with what they had, which was a wealth of data. So for those who were able to be assessed, they actually didn't find a statistically significant difference when looking at admission dispositions, so things like discharged, died, transferred to hospital, and so on. They found a really interesting result that I do want to ask the authors about a little bit later when we start discussing this. They found that almost 25% of the patients that had a trauma alert activated were transported because they met Florida's criteria, were discharged from the emergency department within 24 hours. That's about a quarter of the patients, and I'd be really interested when we start discussing it to see what that was for the folks who were transported by paramedic discretion. But back to the results for a minute before I start asking questions. There were for those that met Florida's criteria, there were 21.4% required immediate intervention. This number was about 12% for those that were transported by paramedic discretion. That was a highly significant result. The p-value was actually less than 0.001. And just as a reminder for those who are on the call, typically p-value of 0.05, less than 5 is deemed statistically significant. They also found a statistically significant difference in mortality. Those who met the Florida criteria, about 7.5 died, while about 2.2% of those that were transported due to paramedic discretion died. They found another interesting result that we'll talk about later, and we kind of gave a little mention to earlier when we talked about clinical and statistical differences. The authors found a difference in the average systolic blood pressure. So for those patients that were transported based on paramedic discretion, their systolic blood pressure was about 122, while those that met Florida's criteria had an average systolic blood pressure of 133. That was also statistically significant. It was less than 0.001. That's an interesting result that I'm sure we'll discuss further in a bit. And they had a couple other things, interesting results that I wanted to mention before we start getting into things. Florida's criteria, so the folks who met Florida's criteria had a length of stay that was slightly over 2 days longer than those that were transported because of paramedic discretion. And interestingly, patients with a psychiatric disorder were less likely to have alert activated by paramedic discretion. However, one thing that this is one of the most interesting results of the paper, I think, is that the authors found that when a patient had both increased age and increased heart rate, they were more likely to have a trauma alert activated and be transported to a trauma center by paramedic discretion when neither of those two criteria met Florida's trauma triage definitions. So it seems like the paramedics in their system were putting things together quite well. So I think that covers a lot of the results.
Yeah, I think you make some great points, Tony, all around. And one of the things I'd like to actually direct our discussion to is the very first thing that you brought up, which is exactly a question from Sahej Khalsa, and his Santa Fe Community College class asked the same exact question in our little question area here on the webinar. It says, the Florida adult trauma triage criteria resulted in almost a 25% discharge directly from the emergency department. So that's what you were mentioning. And their question is, do you think it indicates the tool needs to be adjusted, or is it applied inappropriately, or is this rate acceptable?
Are you okay with this? So a 25%
rate is an over triage rate that is acceptable, right? We want to make sure that we're including all the injured patients, that we're capturing all of those and not missing anybody. So that is an acceptable rate for us.
That's great to know. So, and we know that we're going to have this kind of thing. So is over triage, at what point is over triage, acceptable? Kind of this whole idea though gets to this, how do we even define a patient who, quote, needs trauma center resources? So what would you say to that? How do we define someone who needs trauma center resources? I mean, what would you determine as, because they're discharged from an emergency department or discharged, within a certain period of time, does that automatically indicate they didn't need the trauma resources? I mean, we're not talking about necessarily surgical intervention or things like that, but there must be an assessment level that's different or diagnostic tests that are different.
Sure. So you're playing the percentages, based on the mechanistic criteria. So motor vehicle collision going greater than 35 miles an hour or 55 miles an hour, a fall greater than 20 feet. Those are things that have been statistically associated with many epidemiologic studies as a higher risk of injury if you're hit by a car going more than 5 miles an hour, let's say. So all of those things are mechanistic criteria. Some penetrating trauma, so gunshot wounds and stab wounds, anything above the elbow, above the knees, those are increased risk of life-threatening injuries. So anybody who meets those mechanistic criteria may be evaluated at a trauma center. Then if they have in addition physiologic criteria, so a blood pressure less than 90, a systolic blood pressure less than 90, a heart rate greater than 120, those are our highest level activations. If they have, let's say, a heart rate of 100 greater than 90 or 100 and they're greater than 55, those two criteria may bring them to a trauma center if they meet mechanistic criteria as well. So it is really playing the percentages that somebody with that kind of mechanism and a constellation of physiology and anatomic criteria, long bone fractures, let's say, has a risk of blood loss, a risk of hypotension, risk of shock, risk of head injury, that is significant enough that they should be evaluated systematically by a trauma center. And we know from data from Ellen McKenzie, from Avery Nathans, that patients who are injured, if they're evaluated and cared for in a trauma system, that they're less likely to die. They have about a 20% decreased mortality. So those potentially severely injured patients benefit from trauma center care.
Well, that's great to know. So that's sort of overarching, data, just sort of summary data, not digging into the specifics. But what about the transfers from non-trauma centers? Were those included in this?
They were not included.
So these were original calls from scenes for the most part. Do you have any sense of transferring from non-trauma centers? What criteria or any sense of what happens in that realm?
So recently, we've adopted expedited trauma transfer criteria. So if someone would meet the state of Florida's trauma activation criteria and they're at a referring hospital, they are automatically accepted to our hospital. And we're actually looking at that prospectively to see if that expedites care, if that decreases needless duplication of radiographic interventions, if that leads to improved, less morbidity, improved mortality, that kind of thing. But it's relatively new. Previously, an outside facility, if somebody just, walked in with a gunshot wound to the arm, the transferring facility would have to talk to a provider here, and that could lead to delays if our provider was in the operating room, et cetera.
And that's actually, it's interesting. I raised that question, and then Santa Fe Community College actually just brought up the same thing. They wanted to know about, transporting to other facilities. And do patients get transported inappropriately to non-trauma centers? So there's so many, so many different ways to look at this, right? We have the world of all the people who should be going to a trauma center for services, and then we have those who, what we're looking at here is the population of those who actually were determined by either criteria or paramedic discretion to have gone to your trauma center. So an interesting question too about this whole idea of all those who may have been brought whatever means to a hospital that is a non-trauma center that maybe should have gone originally to a trauma center.
Yeah, we don't know about that with respect to Northeast Florida specifically. We know from national data that patients who are treated at non-trauma centers don't do as well as patients who are treated at trauma centers if you control for injury severity. So and there are places like, let's say, the state of Indiana that doesn't have organized trauma systems. So you're just going to go to whatever the nearest hospital is if you're injured. Whereas Chicago has a 35-year history of an organized trauma system, and Northeast Florida has 25-30-year history of an organized trauma system. So there are places that do have the organized trauma system, and most injured patients will go there. I will say there has been some evolution recently, especially with the recognition that with a lower mechanism, elderly patients can be severely injured with life-threatening injuries. And so there's been extended criteria that have been studied that seem to, if those are adhered to, decrease mortality, particularly for older patients. That's sort of a caveat of that. But we do know, but unfortunately, I don't have any, because we're not all in the same system, and there's not a great way to look at that pre-hospital and then follow-up data from other institutions in the area with whom we're not partnered. It's hard to know.
Yeah. And, this idea of paramedic discretion, a paramedic student is actually asking us, how can we separate paramedic discretion from trauma triage criteria? Isn't paramedic discretion based upon what we learned about triage and trauma? So I think this might be a good point to to bring up in terms of how to collect research data. So how in the data collection were you able to separate, well, this patient was transported or these were transported by these criteria, you know, mechanism of injury or whatever, physiologic criteria, anatomic, versus these ones were solely paramedic judgment. Was there a box they check?
Yeah, there's a box that is checked. I mean, on our trauma triage sheets, and it has the state trauma criteria. If none of those boxes are checked, and it's checked, you know, that it was based solely on trauma paramedic discretion, then that's what they were transferred for. Again, also we did go back and look at to see if even if those boxes weren't checked, that, you know, looking at the run sheets, if they did meet criteria and wound up here anyway, despite, you know, paramedic activated for paramedic discretion, but still did meet the, you know, criteria on, it was potentially unrecognized.
And that was one of our research questions, were these paramedic discretions just failure of recognition of trauma triage criteria? And if you look at or table 1 of the bivariate statistics, you can see that that's not really true. It doesn't look like the paramedics were just missing aberrant physiology, because the blood pressures were higher, albeit, you know, by a few points. We're comparing means and ranges, but it was statistically different. The heart rates were essentially the same, but the Glasgow Coma in particular was higher, ISS was lower, and that translated to slightly improved outcomes with respect to length of stay, mortality, etc. So I don't think that it is that paramedics were missing physiologic criteria. What I do think that the paramedic discretion added value is they sensed that something was different about patients and had a higher risk of injury than someone else who wasn't activated and could go to the emergency department. And that's what we were trying to tease out in our multivariate analysis, looking at interaction effects, because I wanted to see if there were combinations of variables that maybe the paramedics weren't saying, well, these don't really meet criteria, but the fact that, you know, the GCS is a little bit low and there's a long bone fracture. That's why I'm doing this. And by doing it that way, by looking at interaction effects in the regression model, the only thing that we found was that older patients with a slightly lower systolic blood or slightly higher heart rate were ones that paramedics were more likely to activate.
This is why we have authors on, folks, because it's very easy for us reading a study like this to say, okay, so we don't, you know, see these differences. We see a p-value that says it's very different, but is this really different between the two groups? But the point is something that you just brought up, which didn't really even dawn on me originally until you just brought it up, and that is what that Table 1 actually shows us, is that the paramedic discretion is other than the criteria. And that actually, a question from Jamie Kennel was very similar. What portion of paramedic discretion entry didn't meet other trauma system criteria? And you just answered that. You know, how do they get judged as appropriate and worthy of considering expanding the objective criteria? I think that whole idea of, I think Bill Toon said gestalt or gut feeling or whatever, this table actually shows that that's actually what you're looking at. You're not seeing people that have said it's my discretion, but it's actually the blood pressure, or it's my discretion, but it actually in reality it's the GCS or the heart rate that made the criteria. It actually is something else, some other, you know, little person on your shoulder or whatever you want to call it. You know, I mentioned before we came on to the podcast, we were talking and I mentioned to Tony that I had been listening to a neurocritical care podcast that was about looking at this same sort of type of study where you're comparing scores versus clinician determination. And it was prognosticating using an intracerebral hemorrhage score to determine outcome, which, you know, I know it doesn't relate to EMS, but it's the same concept. They were looking at the score itself versus the clinician's judgment in the ICU as to whether or not how they thought the patient was going to do. And they've actually found that the clinician judgment was superior in prognosticating. But the other thing they found out that I thought was interesting is it was different for physicians and for nurses. The physician determination was based on lab values and comorbidities, and the nursing determination was based on family support systems and overall health status and social issues surrounding the patient. So they even used among the providers different types of things to prognosticate, and both of those were better than the ICH score. So this kind of thing, this determining this gestalt, alongside and supplement to an actual score, an established score, is fascinating.
This is Dave, and I'm going to jump in with a comment. And I just love, thank you so much for the authors to be on and for this very enriching conversation to take place. I think that we underestimate the human brain, frankly, that our intuition is reasoning at high speed. So if you read Malcolm Gladwell's book, Blink, and you look at the adaptive subconscious and sort of some of the work that's been done on taking in large amounts of information that cannot be quantified, cannot be, sort of explained, but just the feeling of, I think I'm making this decision based on a whole lot of information that we can call a gut feeling, but in fact has a lot to do with provider experience and the intangibles that would appear to be unmeasurable right now, whether it's, somebody saying I can smell death, or I can feel death coming, or I can, and maybe that has to do with a combination of these things that weren't able to be captured. But what the authors did here is give us a great way of isolating just that adaptive subconscious that's saying, my judgment is, independent of all of these variables, something's wrong, and I can feel it, I can see it, and I can't put my finger on it. So kudos to this group, and I'm glad this kind of work gets done, because oftentimes I think the pigeonholing, but putting paramedics and EMTs in the category of they're just not, their judgment isn't good, leaves us kind of in a bad place. So thank you for that.
Well, thank you for those kind words.
Definitely, thank you.
So I'm going to jump
Bill,
in here.
Yeah, go ahead, Bill.
So I think one of the challenges with this study is its retrospective nature. And to sort of tag on to what Dave was just saying there, it would be very interesting to know the paramedics that used their discretion, how much experience they had, how long they've been a paramedic, how many trauma patients maybe they have seen, because I think there's a potential that would play a role in their decision making. Is, hey, I got burned by this once, I'm not going to have it happen again to me, so I'm going to go ahead and activate in this situation. So
yeah, not a bad thought. I like, I actually have to agree with Bill Toon for once. I know this is kind of like going to mark this podcast.
Wait a second.
But yeah, they did some studies on crew resource management with pilots that were experienced versus pilots that were brand new. These were done in, I think, Sweden or Norway. And the technical ability of the new pilot is superior to the, more experienced, older guy or gal who's got a Rolodex of experiences, but maybe isn't as technically adept with, new tools. And they actually found that while they drew from different points, they could be equally proficient and could actually assist each other. And so in your concept, Bill, I would say perhaps even having a police officer, a firefighter, even a dispatcher who are reacting to information, again, intangibles. Why does a dispatcher's voice crackle on one dispatch versus another? Why does the police officer who's got lots of experience on the scene tell the rookie EMT, you're gonna have to hurry, get your stretcher? And the concept that there's a collective adaptive subconscious, a collective sort of feeling that can actually be biasing indirectly and improperly. So so a lot of times we teach these paramedics to not react to people who are getting all freaked out at the scene because they may not have the same judgment as the others. But those things, I think, contribute to either a bias that's actually harmful and hurtful and makes for bad decisions, or a particular group of people who maybe in group think are capable of cognating at a much higher level. and that sort of cognitive load is, again, something that's been studied quite a bit, whether in simulation, I think in operating rooms as well as in simulation for emergency settings. But that cognitive load that a group can have may actually allow some people who who can influence one direction or another. And again, in the book Blink, Malcolm Gladwell talks about bad decisions like police officers who end up having to shoot somebody because they think they have a gun in their hand, because one officer starts shooting and everybody starts shooting after that. This might be similar in that we have a paramedic or an EMT who panic and start to call something critical when in fact it isn't. But at least from these data, it would seem like something is going on that allows this group. And like Bill says, I totally agree. Be interesting to know what this group is doing that makes them that much better at doing this, and is it true for other groups as well? So nice work.
So, and I just want to follow in, and not to keep the authors out of the discussion, but this issue, at least my personal feeling is we do not emphasize it enough in our educational process of EMS providers at all levels, is that we really need to help them be making the judgment. And I believe it starts as just simple as, does this person look sick or not sick? And then develop them to the point where at least they can come in and say, yeah, this is a sick looking person. And I think that we need to more intensely educate our personnel to make triage decisions at all levels, and so they can develop their intuition or develop their gut or gestalt. And as they get more experience and the kind of feedback they need, this overcomes it, because I think there's something valuable that's gained by the provider who's present in the home, on the street, that is able to take in a whole lot of information that isn't always there for the benefit of the trauma surgeon or the ED physician when the patient arrives at the facility. And I think we need to develop and do a more conscious effort of developing that kind of information in our providers.
Well, now twice I'm going to agree with you. That's truly historic. Unbelievable. Did you take something this morning that made you kind of like a smart person or something? Because I totally agree. The heuristics that are involved in clinical decision making, which are listed in many of the textbooks, just some of the heuristic kind of rules that we teach paramedic students in class actually lead to a bit of confirmation bias. So when they're doing assessments on mannequins that cannot produce different skin tones, the inflection of the voice of the person in a control room actually giving them a simulated case, you're guiding the paramedic student to direct their care based on data that is either blood pressure or a GCS, and you're moving them towards a type of decision making that's quote unquote defensible, because they don't want to stand in front of the trauma surgeon and the ER doc and say, well, why'd you call this entire team? And their answer is going to be, well, because I thought so. Like, wow, that's going to go over real well. Let's get your butt chewed off when the trauma surgeon says, this costs like $20,000 to activate this team, and you did it just because you felt like it. So they get negative reinforcement about just trust yourself, and they get a lot of reinforcement on you follow this algorithm or else you'll find yourself in a heap of trouble. And I think here, Bill's absolutely right. Trying to find, in PHTLS we use live victims and we use moulage, but it's also the inflection of the voice of the patient. It's teaching them that perhaps the blood pressure is going to be normal right now, but look at the pale skin and the patient's ability to mentate properly, and that it's okay to actually send somebody who's just intoxicated. Because I know this was a big when I grew up in the Maryland system. If you flew people to shock trauma off of the Maryland State Police helicopters, and a person who's intoxicated could end up in the operating room within 30 minutes because, gosh, that was the system. You had to be willing to actually send some drunk people to the operating room and get a peritoneal lavage. which thankfully, you know, now we've progressed to other things, but it does mean that sometimes you're going to make a mistake. But on the flip side, it means you're going to catch some people who normally we'd be just kind of going, look, we took them to the local hospital and now their spleen has been bleeding for hours, and this is, you know, a lot harder to deal with. So,
you know,
yeah.
Let me just bring it in for a second because we have a lot of comments coming in, and I wanted to ask the author something that one of the questions that's coming in, and Tony had asked earlier too. So first of all, we've got you know, from Santa Fe, a lot of support for what you're saying, David, too. The authors are talking quite a bit about mechanism of injury, even though we've moved away from basing treatment on mechanism and don't emphasize it as much in education. Instead, we emphasize this, you know, assessment and evaluation of the patient. Are we making a mistake to de-emphasize mechanism? And I think the authors mentioned early in the paper, too, another research, qualitative research that said that part of what the paramedics use is scene information. And then Robert Steeves wanted to support what you were saying with a story from level 1 facility that nurses taking radio reports didn't designate trauma activation from a radio report in a school bus motor vehicle crash because the experienced paramedic was not excited, quote unquote, during the report. And these are, you know, kind of the intangibles. And Chris Ryther also comments about overuse of air ambulances, and we won't get you started there, Chris. He says, don't get me started. So a lot of support for this kind of value of accumulated tacit knowledge and things. But there is a question in here, too, about the research. I wanted to pull the authors in for a second about the that Tony brought up earlier, which is what was the rate of discharge from the ER of the patients where paramedic discretion was used to activate. You had the 25% discharge from the ED for the Florida trauma criteria group, but what about for the paramedic discretion group?
It was a little bit higher. It was more in the neighborhood of 30-35%.
And did you see that as any kind of surprise or any indicator, or was that, I mean,
no, I think it was an indication of what we thought, which was that in general, the paramedic discretion patients were less severely injured and less likely to need ongoing care or admission for ongoing care, which isn't to say that none of them needed that, because the fact that many of them did go on to be admitted and have an average length of stay of 6 days is telling, even though they weren't physiologically terribly injured and their GCS was essentially normal when they came in. So we definitely found that the rate of injury was higher than we would have expected for a random group of people who didn't meet mechanistic and physiologic criteria, so indicating that paramedic discretion definitely is measuring something. We just don't know what. It may have been this sort of the higher level processing of all these data points that don't quite meet significance in our trauma activation criteria, but taken together or taken as a pattern, they indicate someone who's severely injured. So I think that certainly a higher percent that was discharged from the ER shows that our trauma triage criteria work. We have an acceptable over triage rate, but the paramedic discretion should be higher. Otherwise, we should change our trauma triage criteria and incorporate those patients in somehow. But
yeah.
But I do think that we were surprised by. We thought that they would actually be a much more different population, and they were statistically different, but not as dramatically clinically different as we thought.
Yeah, that's a great point, and that's something I think that Dr. Fernandez brings up in his article, the difference between, you know, the statistical significance and then clinical significance, and that's and working together with both of those. Is there anything that you really wish you would have measured? You know, at the end of a study, you kind of, especially when you say things like something surprised me, which is the beauty of science, right? Something can surprise you. Is there anything you really wish you would have measured, or you think, okay, well, this will take to the next step?
I think it's more the latter. I think we were happy with what we were able to pull from the retrospective data. But what it did do is, as you say, stimulate ideas for further research. So we're actually working on a paramedic discretion survey that we can collect data prospectively in real time and get more granular with some of these reasons that paramedic discretion activations happen.
Yeah, and that's what actually Santa Fe Community College, you guys are like reading our minds here. So they asked, was there any interviewing of the paramedics who used paramedic discretion to activate to determine why they chose to do so, or thought to doing that as a follow-up study. So guess what? That's exactly the case. Can you run through limitations of doing a study like this and the limitations, even though it's in the paper, but it's nice to review those with our students out there?
Absolutely. So the biggest one is that this is a single institution study in a state that utilizes paramedic discretion. So in states that don't use paramedic discretion, and perhaps in other institutions that in the state where their local pre-hospital providers don't rely as much on paramedic discretion, this may not really be generalizable. We also, in Florida, there are level 3 traumas, which is not something that is used in many other states. They're simply level 1 and level 2. And level 1 is, the really sick, the patients who were in a car crash and have a blood pressure under 90 and, or they're shot in the torso, those kinds of things. And level 2 are just basically mechanistic criteria or shot in the hand, the foot, that kind of thing. In Florida, there are also level 3 criteria, and these have been shuffled around a bit. So don't write any of these criteria down and expect the state to adhere to them. But some of them are a little bit lower mechanistic criteria. For example, a level 3 might be a fall from 10 feet as opposed to a fall from 20 feet, or a fall from standing, but greater than age 55, that kind of thing. So that may be a level 3 activation. And it doesn't. And the jargon is important too, because they're not called activations, they're just called level 3 traumas, just to, exhaust and frustrate yourself with the semantics. But so those are some of the limitations, are the things specific to Florida and to our institution. Also, it is a retrospective study, and we were unable to obtain survey or real-time data about why the paramedics activated that particular person. A real-time correlation of the vital signs, of the appearance of the patient, of maybe photographic details of a crash would be really helpful, and that is something that we have submitted to the IRB, and we have a survey instrument in place. So we're hoping to get that started in the next couple months.
Oh, that's terrific. We look forward to following that through. This has just been a really rich discussion. Tony, can I bring you in here? You might have had some questions too about the results. You had said something about wanting to ask the authors something about the results.
Yeah, hi, and thanks. Real quick, I think it's important, since a lot of the folks online and listening to us are students and budding researchers and such. There's to talk about the systolic blood pressure result. I think I said 122 versus 133 earlier, but it looks like I misspoke. It was 126 versus 133. And that was very statistically significant. And I know it's hard to say when you're not actually looking at the patient, but I was hoping that the authors could help in a discussion of the difference between a statistically significant result and a clinically important result, and how the readers might tease those out.
Right, that's a really important point. So the systolic blood pressure difference, if you look at the way you determine statistical significance is when you're comparing two populations, is the average number and include the range. So our range here is, plus or minus 32, and then 133 plus or minus 27. And then if you were to draw this out as like a bell-shaped curve and overlap the two, because there's such a huge number of patients and it's so tightly crowded around the mean, there is a statistically significant difference. So the higher the number, if you have 1 million patients in each arm, an age difference of 38 years and 39 years is going to be statistically significant, just because there's such huge numbers, whereas the clinical significance of that is probably limited. I will say, though, we have found that even though the patients that were activated as trauma criteria, the systolic blood pressure is a little bit lower, as a population, they were more likely to meet trauma activation criteria because of having one of those things, like a systolic blood pressure under 90 or a heart rate greater than something. So it might have greater than 120 or whatever. So it might have been more clean to look at medians because the median for those two were a little bit wider disparity. So the median for systolic blood pressure in the trauma activation criteria, especially for the level ones, was like, for the level ones, it was like 86. And for the level twos, it was like 120, 122, 130. But because there was such a range, the mean was actually higher because fewer patients were hypotensive. Whereas with paramedic discretion, it wasn't as much, the mean and the median were closer together, if that makes sense. So for those of you who are studying statistics, you'll see that the comparison of means, which is much easier to work with statistically and is generally what's commonly reported because of reader familiarity with those, they don't look all that clinically significantly different. But had we broken out the activation criteria medians and the paramedic discretion medians with ranges and quintiles or quartiles, it would have looked a little more different.
Yeah, and maybe, Tony, could you comment on mean versus median for the students out there?
Yeah, absolutely. So anyone who it's been a little while since you took statistics, just the mean is essentially your average. It is your average, and it's a mathematical formula. So you're depending, if you have things that are way outside or way inside, that are outliers for either under or over, that can really change what your average is. Whereas when you're looking at a median is simply your middle number. So if you line up all your systolic blood pressures from lowest to highest, and you pick that, you find the one that's in the middle, and you pick that would be your middle number. And there are different statistics that you do depending on if you're using a mean or a median, as the author was kind enough to address. When you're anticipating differences and a large range like that, or that your data are not quote unquote normally distributed, a lot of times you do work with medians rather than means. So I hope that wasn't too far into the weeds.
Yeah, that's perfect. I think it's always helpful to talk to the students out there. We are rapidly approaching the top of the hour, so I wanted to extend to the authors our gratitude. Thank you so much for being with us. And could you do you have any kind of closing comments or anything that you'd like to maybe address the paramedic students out there, or any of the budding researchers?
From my perspective?
Yeah, just, I mean, if you had to talk to people as though they were the ones out there, you know, completing charts and filling out research forms, yeah, and they're just learning right now. Is there any advice you can give them?
I would say that I came to the research game a little bit late, and now I'm finding everything fascinating. So, you know, learn your craft, and if people ask you to participate in research and you're interested in figuring out how we do what we do, and if what we do is the best practice, I think research is just invaluable for that. I have a passion for evidence-based practice, and nothing makes me crazier than arbitrary rules. So if you're like me and you want to put that together, then research is a good place for you.
That's great.
What a great comment. You know, I thank you so much. That's evidence-based practice is where we should be and where we want to be. And what I love about this podcast in particular is the sense of collaboration. If EMS and general pre-hospital care doesn't get the punchline, if we don't know what the end results were, we're just going to keep kind of shooting in the dark, and we don't know what best care might be unless we find out, you know, we make a very deliberate alteration, measure it, see it, and then see what the downstream results are in discharge outcomes, survival outcomes. So I do think that if you're listening to this podcast, finding great doctors to work with that are passionate, like Dr. Crandall, that can help do a partnership with EMS agencies so that we do feedback, actually what happened. And at the very simplest level, because there's paramedic students listening here from all over the country, simply finding out what happened. So you don't need to be doing a heck of a lot of research to simply start your own little research database on, gosh, I just followed up on this patient that had abdominal pain, and it turns out they had a big AAA. But we don't do that if we just leave the hospital and never get that information. And anybody who says, there's HIPAA barriers, those barriers can be overcome with clinician to clinician contact and communication with the nurse you drop the patient off for, and saying, this is part of our QI process. It's not gonna, it helps us improve. So I think it is time to do some more concentrated work on how is it that that intuition and reasoning at high speed can help us improve patient care in all sorts of different directions. This is a great example, but sepsis might be another, and there might be many other ways in which we can teach that paramedic programs and instructors online can help create and research that in a classroom as well as in their clinicals with their students. It's a perfect petri dish of paramedic students in an emergency department where they're flowing through, and we can find out if in fact in paramedic school they're actually better at figuring out who's sick and who's not. And I think that's a great way to go.
Great, thanks. Dr. Ebler, did you have any final comments?
Dr. Ebler had to say goodbye because he had not one nut, but 3 pages down to the ER.
Okay. He's probably been gone a couple of times during the course of the podcast. Well, we wish you both good luck in your next phase of the research, and thank you very much. I want to know if Bill Toon or Tony, do you have any final comments?
I just also want to say thank you to the authors, and I look forward to their future work that they're going to be doing in this area. And I do think it would be very interesting to do some comparisons between the Florida trauma triage system and the national triage system to really see the differences, if there is any, and stuff. But there's lots of exciting things to be studied. So thank you both very much.
Yeah, and I just want to add to say thank you, and thank you for joining us. And to everyone listening, I really hope you get a chance to read this manuscript. I think the authors did a great job of putting their results into context and explaining these results. I think it was really well done. So I encourage everyone online to not just stop here, but try and get a hold of the manuscript and read that.
Another great one.
It was a great time for both of us.
Great, thank you. Thank you all, and thank you to everyone out there who's been listening, and good luck to everyone. And those of you who are just learning this, remember now documentation is key, accurate documentation. So we want to thank everyone for joining us today. And one last final reminder that April 30th, 2018 is the deadline for new abstract submissions for the 2018 National Association of EMS Educators Symposium and the EMS Expo International Scientific Symposium. And we will see you next month. If anyone has an idea for an article or would like to contribute to the next month's podcast or future podcasts, you can always email David Page at dpage@emsed.net. That's dpage@emsed.net. See you next month.